From the campus of the University of Kentucky, you're listening to Behind the Blue. I'm Cody Kaiser with UK Strategic Communications. It's hard to believe it's been 5 years since the COVID-19 pandemic officially arrived in the Commonwealth. But on Friday, March 6, 2020, Governor Andy Beshear confirmed the state's first COVID-19 positive patient and declared a state of emergency in Kentucky. And the hospital that confirmed that first case was right here at the University of Kentucky Albert B. Chandler Hospital. That day began a grueling, years-long grind for medical professionals across the state, the country, and the world. Hospital systems struggled to keep up with surges of severely ill patients coming through their doors. Shortages of personal protective equipment, ventilators, ECMO machines, inpatient beds, and even healthcare providers themselves led to a type of global health crisis not seen in more than a century. On today's episode of Behind the Blue, you'll hear from 8 longtime employees from the medical side of UK's campus, ranging from administrators to reflect on those scary early days of the pandemic, how it impacted their professional and personal lives, and some of the lessons learned from living through such a significant moment in history. And now, let's meet our guests today.
I'm Kevin Hatton. I'm the Chief Medical Officer for Chandler Hospital. In 2020, at the start of the COVID pandemic, I was the Senior Medical Director for Critical Care across the enterprise. I was also the Interim Director for ECMO Services.
My name is Kimberly Blanton, and my current title is Chief Nursing Officer for Chandler Campus. I was the Enterprise Director for Infection Prevention and Control, Vascular Access, and our Interventional Services, as well as our Cardiovascular Service line.
I'm Rob Sprang. I'm the Director of UK Telecare. What I do at UK is run the telehealth program. We began telehealth at UK in 1995, and we have built the program since then.
I'm Vince Venditto. I'm Associate Professor of Pharmaceutical Sciences in the College of Pharmacy. I was an assistant professor when the pandemic started, so yeah, I've been promoted since then. It's very exciting.
I'm Ashley Montgomery Yates. I am a physician in the Division of Pulmonary Critical Care and Sleep Medicine, and my official title is the Senior Vice Chair of the Department of Internal Medicine. In March of 2020, I was officially the ACMO of inpatient and emergency services for the enterprise. At that point, we had one CMO and a couple of ACMOs, one in procedural area, one in ambulatory, and one in sort of inpatient and emergency services. And I was that person. The CMO had left UK to take another job. I think he left the end of February, very beginning of March, and we were in the process of interviewing for a new CMO. And then March happened.
Yeah, I'm Dr. Lindsay Ragsdale. I'm the Chief Medical Officer for Kentucky Children's Hospital and Maternal Services. I'm also the Division Chief for Pediatric Palliative Care.
My name is Meg Piper, and I am a Divisional Charge Nurse in the Emergency Department at UK. I had been a Division Charge Nurse, which is a fancy way of saying charge nurse. It's just charge nurse in the ED. And I had been trained as a charge nurse years before, but I only did it like relief charge. This was the first time that I took on the title, and I did it right in the middle of COVID. I really had really good timing on that one.
I'm Jen Alonso, and I'm a registered nurse in the medicine ICU. And I was actually there when they announced the first patient. I was in the unit.
In late 2019, the world began seeing reports of a novel, deadly virus that primarily attacked the lungs, originating from Wuhan, China. Mass cases of viral respiratory illnesses are nothing new. In the previous 2 decades alone, the world has seen a number of widespread deaths stemming from these viruses, including the SARS epidemic in 2003, the swine flu pandemic in 2009, and the MERS epidemic in 2012. As national news outlets reported on the rise of infections and death rates in China, health professionals here had differing thoughts on the potential impact of this yet unnamed new viral disease. Those thoughts evolved as they watched the novel coronavirus spread to other Asian countries and then to Europe and North America.
What was I sort of thinking in November from a ICU provider standpoint? It's comical to think back to it, but I don't think we really thought anything of it. I had lived through the H1N1 pandemic as a provider. We'd had a relatively recent Ebola scare just a few years prior. There have been various respiratory diseases, MERS and others that affected the world, right, and caused some panic, and the news talked a lot about it, but it didn't affect us in Kentucky, right? It was a thing that existed, but we felt maybe clearly naively about that it was going to burn itself out, or it was a problem that someone else was going to have to deal with, and that we weren't going to have to deal with it. So I'll admit I didn't think much about it. Even as Italy and other places in Europe started to be affected, I don't know that I really still continued to think dramatically like it would impact us in the United States, in Kentucky, the way that it ultimately did.
On a personal level, I wasn't worried because I've been in healthcare so long, and we've lived through not a pandemic, of course, in my time, but other emerging diseases. And so I knew that we were, as a team, going to be able to handle it if we did basic infection control. I don't think I had any idea that we would get to a worldwide pandemic originally. And so personally, I was not one that was going out and buying all the toilet paper and the hand sanitizer. I was thinking we're going to be able to manage this with just our day-to-day. From an infection control perspective, we immediately began to run through some of our protocols for an influx of infectious disease patients. But I also was thrown in to the campus work. In November and December, the president and the team asked me to get involved with our international students because we needed to bring them back. They were going to close international travel, and we knew that. And so I began to really collaborate with the International Student Center and that team, and I helped once the students got back with them and their parents. I was their go-to to answer questions. I did their follow-up for 14 days post-travel and talked with them day and night to make sure they had what they needed. As I was working with the students and their parents and bringing them back, I was hearing what they had been seeing, right? Because I was talking to them every day. And we were isolating them to be safe because we brought them back, right, from these areas that was closing. And I kind of felt like if this happens here, this is going to be a thing, because isolating these folks from their families after all they'd been through, I could feel the emotional drain in their voice and the parents that were calling me. So I had that piece. And then when news popped up that it was happening in New York, I, like Dr. Hatton, was like, this is coming here, and we really need to be prepared. And so I do think it got more real for me, professionally and personally.
I honestly blew it off. I remember my mom called and was like, oh my gosh, this COVID thing. And I was like, Mom, calm down. I said, the flu kills people every year. This is just another virus. This is nothing. And then as it kind of progressed, then it was, I remember I had a coworker who he was kind of like knew about it way before it was like on the news. And he had pulled up these videos from China of these people inside of their workspaces just working on a computer, and there were other people behind them with like full-on fumigation suits just like spraying the whole room. And I'm like, whoa. First of all, those poor people at the computer, because they had zero things to protect themselves. They were just like, didn't have anything, and these guys were in this hazmat suit, and I was like, that can't be good. But it was stuff like that we were seeing, just like snippets of it overseas. And then I think once everything happened in Seattle, I think was the first place where it was that nursing home. I think that People were dying. And once stuff happened in Washington State, I said, oh, crap. Yeah. So I didn't think it was going to be anything like what it was.
I was paying attention to the news. I really like to understand what's happening globally, but it really felt like one of those avian bird flus or something that kind of passes us by. So at that point, I wasn't paying a whole lot of attention. At that point, we hadn't seen many pediatric cases globally, so it was mostly affecting adults. Although we always hold our breath whenever there is some kind of widespread viral infection that it will affect pediatric patients, and just making plans the best we can. But at that point, we just didn't know. We had no idea what was coming our way. It really wasn't until the U.S. had their first case or Kentucky had their first case where I was like, oh, okay, we're going to need a plan for this.
When the news first came out in November of 2019, it just seems so removed from us that it didn't really, I didn't feel like it had an impact on us. But you could see over time, it got closer and closer, and it became clear, especially the way people travel, it's going to find its way to the U.S., to Kentucky, and certainly to UK. It was so separated from us that, no, I wasn't worried. And even the reports of the severity of the illness and all, it just, back in that time, it just didn't seem real yet.
I had heard about it, but I wasn't really paying attention. I didn't really think, you hear about, oh, there's this influx of people somewhere in the world that are getting sick. And I just moved on with my day because it wasn't here. I'd never, people were sounding the alarm, but it didn't really hit me until it was here. I was concerned when it started hitting the West Coast and then New York. And I had a friend that lives in Brooklyn, and she was messaging me and telling me that she was, leaving the city to go upstate and get out of that environment because it was very terrifying to her. And that's kind of when I started paying attention.
So I think as an internal medicine physician especially, all of those sort of subspecialties fall within that department. So the infectious disease people and, the respiratory and the liver. So I think there's a sense of all of those subspecialties. We pay attention to them more than, say, some of the very subspecialized, say, surgical or like an ophthalmologist or something, right? So I think we knew it was happening. And I remember watching and thinking, oh, that's bad, right? That's not good. But it's China. There's lots of stuff that happens in China medically that doesn't happen here, right? And so I think although we were paying attention, there's also this sense of, oh, it's over there, right? That's because those people aren't doing what they're supposed to do. That would never happen here. And we felt very protected. And I think with good reason, like we'd also sort of lived through Ebola outbreaks and SARS and like other things had sort of come and had affected other locations around the country, but had never really come to the U.S. I even remember I have a fairly medical family and talking about it a little bit at Thanksgiving, like, oh, do you see what's happening? And well, it's bad and all that. But again, there was a sense of sort of immunity to it, I think, from us, that it just wasn't going to affect us that way.
So I was paying attention to it. I think that the College of Pharmacy is a bit unique on campus because all of our administration is infectious disease background. So with Kip Guy and Frank Romanelli and Craig Martin, they're all infectious disease background. And we were hearing a lot from Kip and his interactions with his friends on the WHO, on the World Health Organization, that this was going to become a problem. So, and because my wife Christy was the communications director for the college, she was involved in all of those meetings with Kip. So she was preparing for what Kip thought was going to become inevitable. And they were already beginning to communicate that with faculty and for us to basically have plans in place for a educational shutdown, for a lab shutdown, for all of those things. So I was kind of getting that from Kip through Christy, and so did I think it was going to happen? I thought that there was a chance. Kip's a pretty smart guy. He's got smart friends. I thought it was probably going to, affect us. I didn't anticipate it was going to affect us the way that it did and have us shut down for as long as it did.
I think as we saw the spread from what felt like to China, to Italy, to New York, I don't know that I didn't as a doctor, right? And my family as well, right? We didn't really perceive this as a change. Even when we would see on the nightly news the horrificness coming out of Italy, it didn't really change until New York, right? And then, right, it's in America, it's Americans, and it affected us, right, in ways that we could very clearly see, right? We would see images on TV of places that we had actually been, right, visiting New York, and that's for us a time when it became serious. Not yet like a degree of serious like it would ultimately come a few weeks later, but that's for me the first time that I thought, this is something I don't want to say that I should pay attention to, but that like might affect me in some tangible way.
Yeah, I went to a conference and I can't recall. I thought it was early February, as I remember. And my wife was like, "You can't do that." And I'm like, "Of course I can. What's wrong with it?" I was supposed to speak at a conference and didn't think anything of it. I got there and there were actually quite a few people that didn't make it. But for the most part, conference was fine. But then getting on the airplane coming back, it was a real different vibe. People were covering up. I mean, there were people just sitting with a blanket over their head for the whole flight back. So that was my first recollection. Things are different.
So honestly, I think it wasn't Seattle for me. I think it was Italy. When it hit Italy and really ran rampant through the Italian communities, I think for those of us here, we were like, oh, wow, that's not a third world country. That's a place I go visit. That's a place at that point in time, my sister was living in Sweden, but she had just moved from Italy. So it felt very real. And I remember thinking, Italy is not a bunch of unhealthy people in general, right? It's not unclean water or unclean air. This is just like America in the living environment, maybe even healthier. So I think when it hit Italy was when I began to really pay attention. And I think when it hit the U.S. and it first started, everyone was panicked. But there was still a sense of control in okay, it's going to come, we're going to isolate, we're going to do things, we're smart scientists, somebody's going to figure out what to do about this. We have really great higher level care models, and we're going to be able to people aren't going to die here. That's not what's going to happen. And honestly, I think from the end of February until March when it hit us, and we were actually fairly early for sort of the center part of the United States, it all happened so fast. And so every morning you just woke up and were like, what is happening? What's going on? And then all of a sudden it's on the news and you're talking to your friends in New York City. And I had lots of friends in New York City at that point who were in those hospitals or in those areas. And it was just unreal.
In the early months of 2020, this new viral disease would get an official name, Coronavirus Disease 2019. More commonly known as COVID-19. On February 29, 2020, the CDC confirmed the first COVID-19 death in the United States. By early March, it had spread to more than a dozen U.S. states. And when it officially arrived in Kentucky and at UK Healthcare on March 6th, many of our healthcare providers remember exactly where they were and what they were doing when they learned the virus had hit home.
Where was I? Well, that's funny you should ask, because yes, I'll never forget it. My medical partner and I had just finished up a 2-day intense simulation here with the state health department, our local health department, and our first responder team. And we actually had Emory in Nebraska kind of help us with some of our simulation. We had just finished with NETEC helping us. And so I thought we're prepared. And I left here, it was on a Friday, and the next day was the heart ball. And I had gone to get my nails done for the heart ball, and we knew that this would happen. And I am sitting in a chair at a nail salon getting my nails done when my medical partner, Dr. Forster, called and said, "You need to be prepared. Our patient is positive." Because we knew she had come in. She had a lot of the symptoms. We'd already begun some of our thought process through the day. We knew she was coming. He'd been involved from the beginning. And so we kind of knew, but then when he said it, I was like, okay, I got to go. I can't stay in this nail chair. I got to go. And so then began our couple years of the pandemic.
I was at our church doing a volunteer meal packing, and we were several hundred people, sort of getting the lesson about how to do it in a safe and effective way. When someone got it from on their phone or something, and you could sort of feel it percolating through this massive crowd that, oh, we have one.
I was working the desk when that first patient came in. We didn't even know what we didn't know. And I remember that around that same time we got another patient that was altered. I went into the room to help, take care of the patient, and they were in room 63. And then a couple days later, they called and said, who all was in that room? And we just went in there like we normally go in. And I made a list of all the people there, and they were like, we think he might have COVID, and then everybody had been exposed. It turned out that he did not, so it was fine. But I just remember being like, okay, there's this one, so it's here. Like, I just remember being like, well, this is happening. Yeah.
I don't recall, and again, it still was a little distant for me. I don't recall what I was doing. I do recall that we kind of immediately mobilized and said, it spread, from China through the rest of the country, back to the United States, back to Lexington. We got to be prepared for this. And honestly, what worried me most was, how do we protect our providers who are going to have to give care to people? Because they can't get sick. And so we began to strategize on how to do that.
So, I was the ACMO of inpatient. So we had talked a lot about sort of symptoms and what to look for. And there was a patient in the NICU, and it was one of my colleagues, right? This is my division. It was admitted on my unit. Called me and said, I think we should send this person's, we should test for COVID. And I was like, what are you talking about? Like, it's not here yet. We haven't seen it here yet. And they were like, this person has the symptoms. And I was like, and the symptoms, means everybody knows, they're kind of vague, right? They're just viral symptoms. But this person was really sick and was a fairly healthy young person. And it's not that we hadn't seen that before. So I remember kind of rolling my eyes and thinking, what are we doing? Because at that point, we didn't have rapid testing. You had to send serum and respiratory cultures to the state. You had to pretty much go in lockdown and, all the containers and stuff. And I was like, okay, sure. This seems a little crazy, but okay. And I remember calling Derek Forster, and he was like, we're going to do this. And I was like, okay, sure. He was like, I don't think it is either. I think this is total overkill, but I'll call you if anything happens. And I think we sent it on a Wednesday, and my sister was coming into town because there was a family friend in the hospital, and she was going to stay with me. And I remember she was at my house. It was Friday evening or Thursday evening. And I looked at my phone, and it was like 9:00 at night, and it was Derek Forster. And I was like, he wouldn't call me if it were negative. He's going to tell me something horrible. And I remember answering the phone and thinking, oh no. this is not good. And immediately hanging up and saying I have to go into work, and sort of arriving there, and people were, I don't want to say mass hysteria, but there was some fear. What is this? What's it going to do? How's it going to affect us? And the first patient had a spouse or a significant other that was with them. And I remember walking up to the MICU, and the MICU's all glass doors, so you can see in the rooms, and sort of getting up there, and they had, there were like things outside of the door, and you could see through the glass doors, and the patient was in the bed and very sick, and the spouse was kind of in the room, and it was just this surreal, like, holy mackerel, like looking down the hallway and seeing them through those glass doors and thinking, what is this going to look like?
Yeah, I had this distinct memory. I was seeing a young adult actually in Pave, and we were on the 8th floor. And I remember hearing, how the grapevine is that the COVID patient was coming to the 10th floor. And this family looked at me and said, I've heard a rumor that the COVID patient is coming here, and we want to get discharged today. They weren't even on the same floor. They had no idea. There was no way they could have known. But I think that was a defining moment where, oh, wow, like this is really going to hit us. And patients wanted out of the entire hospital that day. That was really distinctive.
When it was announced that we had the first patient, I was in the unit, and that patient was in our unit. And there was a flurry of activity. And that's, at first I didn't quite tell everyone in the unit what was exactly going on. I believe the charge nurse knew, and the primary nurse of that patient knew, because they had pulled him into a meeting, and I think they were trying to figure out what the next step would be. So it was terrifying to see how many people came into the unit and trying to figure out what we should do to keep everyone safe. I thought, okay, it's just one patient. I'd never seen anything spread like this before. Like the flu, it spreads, but the flu, you can have some patients who get very sick, but it's not all the patients in our unit that have the same diagnosis, the same amount of sickness, that are needing all of the things that we were able to provide. So I didn't think it would be as bad as it got later on.
On March 11th, 2020, with more than 118,000 cases and 4,291 deaths from this new virus reported across the globe, the World Health Organization officially declared COVID-19 a pandemic. Most states, including Kentucky, began implementing quarantining and lockdown measures. While many people were unable to work or began working remotely, those in the healthcare industry never stopped caring for patients, and most were working longer and harder hours than ever before. This all while witnessing unprecedented levels of sickness, death, and sadness, especially when the deadly Delta variant of COVID-19 hit Kentucky in late summer 2021.
So my job during this time really took a turn. I went from directing to really just getting in the weeds and helping the team. We couldn't take the calls quick enough. And it was calls from we don't have the right supply to we don't know what to do. And the protocols were changing every minute, and we didn't even know what tomorrow would bring. And so I spent hours calling patients and letting them know they were positive and educating them on the phone and just trying to make sure they understood, you really are positive. Oh, there's no way I don't have a symptom. I am assuring you you're positive. And it was all day. And the amount of people that just needed you, my phone never stopped. And just really their anxiety, trying to deal with the unknown. I didn't know what tomorrow would bring. I didn't know how the rules would change or the protocols needed to adjust, but I had to be able to really make sure people to lower their anxiety, and they depended on that. And then, of course, the supply issues started. And then we didn't have gloves, and then we didn't have hand sanitizer, and then we didn't have gloves, and we didn't have gowns, and we didn't have the right masks, and everybody needed a PAPR, and we didn't have enough PAPRs. And so at that point, I really do think it was just the most overwhelming feeling of everything coming at you and what are you gonna do next? And you really have got to maintain your composure because everybody's depending on you to know the answer. And so thankful for our collaboration with campus, our KDPH friends at the Department of Public Health, with their stockpile and how they helped us. But in particular, thankful for the supply chain here. Laura Miracle and her team, we came together and we spent a year and a half in C104 handing out supplies. People called it rationing because we took it off the shelf. And I'm like, we have no choice. We have to be prepared. And so it just was day in, day out trying to honestly swim upstream.
My team, the anesthesia critical care team, we typically don't take care of patients on a day-to-day basis that would be COVID positive. That typically falls to our medicine ICU colleagues. So the way that it really affected us was we knew that there were going to be a whole lot of patients that were going to come to our medicine ICU colleagues with COVID. But we also knew that the normal diseases that people have and that would need to come to the ICU would still need to be seen. So our role was to take care of patients that were not COVID positive, but had a number of disease states that still needed intense ICU care that were not our normal population. So we had to learn very quickly a degree of ICU care for which we had been trained, but that weren't part of our day-to-day care. So we had a lot of very quick learning about liver failure and kidney failures and all kinds of things that were quite frankly helping the rest of the population to continue to live as normal a life as they possibly could while this pandemic was raging around them.
I think my job became the pandemic. I was responsible for helping to decide and design care models and sort of thinking through what we were going to do. I can remember, with the CMO gone, it was okay. I remember calling the next level up and saying, I think we need to have a meeting and I'm going to need to invite people, doctors and groups, and we're going to have to think about this. And I remember we had a meeting in sort of that large room in the bottom of the Children's Hospital with the dry erase board. And I remember walking up, and at that point I was more junior than I am now. And there were a lot of people in that room that to me were authority figures. And thinking, okay, here we go. I'm about to somebody's got to make decisions. And so sort of walked up and said, okay, this is what's happening. This is what we know about this virus. This is what we think is going to happen. And at that point, we didn't know. We knew it had happened in Italy. We knew it had happened in New York. We didn't know how it was going to come to Kentucky and spread. And we knew we now had one sentinel case, but what did that mean? Was it everywhere? Who else was going to get sick? And so we began sort of designing the system in that room with the dry erase board and talking about, okay, how many people should we have on a ward? Who do we need to take care of people? What are we going to do if we get 1,000 COVID patients? Where are we going to put them? How are we going to do this? What are we going to do with surgeries? All of those sorts of questions began rolling through our minds. And we were talking to lots of people at other facilities, and I think they were a little more blindsided than we were, New York and Seattle specifically. It just came on them, whereas I think we had a little more time to plan. And so we planned, right? We made sort of in a military format, squads and rotations, and people got different jobs. And, we sort of said, okay, who needs to man the ventilator? It's the people who know how to take care of the ventilator. Who are those people? Who can help with turning patients? Who could help with moving patients? Who could help with, giving infusions or shots or vaccines? Or what do we do if somebody breaks their leg? So we sort of had a whole plan for using the structure of everybody in the university to the best of their ability, right? And even people, I can remember specifically we had classes where we were like, okay, here's emergency ventilation 101, and sort of taking like the orthopedic surgeons and saying, okay, we're going to teach you what to do if you're in crisis and you can't find anybody in the vents doing things. Here's some things you could do. And everybody was super willing and really wanted to help and tell me what I can do. And We had trainings and everybody showed up and no one complained. It was kind of surreal in society in general, but it was scary and invigorating, and you just were sort of preparing for the worst and hoping it didn't happen.
From my perspective, while we had been doing telehealth for 25 years, COVID exponentially grew what we were going to do. Not just the opportunity to do it, but one of the things that we had battled for 25 years is the legal and regulatory world that kind of restricted telehealth. And suddenly, and fortunately for us, especially in Washington, Congress and healthcare agencies moved forward very quickly to tell providers, we're not going to restrict what you do with telehealth anymore. Do what you can to take care of people. So historically, telehealth was done facility to facility. A healthcare facility refers a patient to UK that needs a specialist. That was done because the reimbursement model that had been created, especially for Medicare, allowed that. Fortunately, in Kentucky, the state legislature allowed patients to be at home. But what happened with COVID is that immediately people realized, I don't want to go to the hospital, I don't want to go to the clinic, because that's where all the sick people are. With good reason. We don't want to contaminate people. And so people began to stay at home, but also realized, I still have healthcare needs. I still need to see my clinician, still need to get my medication. And so immediately telehealth took on a much greater role than it did. And it was 7 to 10 days of working all day, every day, to get to the point where we could see people from their homes. It was pretty hard to separate a personal life from a work life just for those first 2 or 3 weeks, because we had one focus, and that was to make sure that we took care of not only our patients, but took care of our providers. And so one of the first things we did, and I think what worried everybody, was what's going to happen in the emergency room. People are going to wander in with their family, extended family members, and they have COVID, and everybody is going to get COVID. And so we immediately started working to put telehealth into every emergency room, both at Chandler and at Good Samaritan, and we were shocked at how many encounters somebody from UK, and it wasn't always the clinician, it wasn't always the physician, could have been the nurse, could have been support staff, that we just don't realize how often people walk in the room. And then concurrently to that, if we remember, we had a nationwide PPE shortage. So suddenly, we didn't want our providers to get sick, but we also couldn't protect both the provider and the patient because there were no masks, there were no gowns. And so we had to find a way to reduce the in-person contact between somebody from UK and a patient and family member. And we actually found that was telehealth inside our own emergency room. So our provider could have been in an office or a hallway 30 feet away, seeing a patient in the emergency room, exam room, through an iPad.
The pandemic upended our world, to be just blunt. It changed everything about our ICU. We were a team before, but we had to really work together to keep each other safe, especially in the early days, because we didn't know anything. We didn't know how this was spreading exactly. I mean, we knew it was respiratory, but we didn't, the first few patients that we had, if we touched something, we had to go and change. And if our scrubs touched anything, we were go take a shower, change your scrubs. So we were very, very careful, and we had to watch out for each other. it changed. We became kind of a lockdown unit, and everyone that was there at the beginning, we were the nurses that were the frontline nurses. We were exposed, and we didn't. Our hospital UK worked really closely. We worked very closely with infection control, with Kim Blanton, to create a safe environment and protocols, to put those in place. But at the same time, we were essentially isolated from the rest of the hospital. That's how it felt, because we didn't get relief in the beginning. We were the exposed nurses. We knew what we were, we had worked with them for a couple months, and therefore we knew what to do, and they didn't want to bring anyone else in. So that was kind of a bitter pill to swallow at first, because we were getting tired. After I think it was about 9 months, that's when we started getting other nurses to come in and relieve us from having to take these very sick patients every single day.
Certainly when the pandemic started and we had the ability to do, to analyze blood samples, we started going down that route of trying to get, testing available for campus. When it became clear that that wasn't going to happen, it kind of pushed us in this new direction where, we started this clinical study called PROTECTS, which is, pharmacy-based recruitment of subjects for analysis of blood samples. And we set it up in the context of COVID, but we're now approved for other infectious agents and inflammatory conditions. So we can basically recruit subjects and test for anything. And it really is a completely different and innovative way of thinking about doing clinical studies. That certainly changed the trajectory of some of the projects. And I think that I probably would have gotten there doing exactly this project. It was just accelerated by the pandemic. It's because I have this cardiovascular biomarker that we've identified in the lab with specific patient populations that we've tested. And, as we try to figure out what that biomarker is, why people have it, we want to be able to recruit specific populations. Because we use phlebotomists to draw blood and collect samples from subjects in the community pharmacies, this provides pharmacy technicians an opportunity for growth, professional growth, and workforce development to give them an extra, task, something else that they can achieve that then provides this service in the community pharmacies long term and really assists in care specifically in rural communities. And so being able to recruit patients in subjects in the pharmacies in communities where they work, it's a very clear path for us to do something that's really innovative that would be received very well by a NIH study section, hopefully. So yeah, I mean that to me is probably the most impactful.
So I took over as the chief medical officer in 2021, and from 2020 to 2021, pediatrics had not been affected very much. Really, our biggest fear was that all of the pediatric providers were going to be pulled to take care of adults in this platoon model, where there would be an adult ICU physician, and then all of us were going to just be hands to help. And they were really struggling, all the patients on ECMO. And then we started seeing a big pediatric COVID surge. And it was the exact same time I took over as chief medical officer. And I think I remember my first meeting, it dawning on me that we did not have a very well-developed surge plan for this kind of pandemic. We had never faced this before, and before it started affecting children, we mostly were just worried about being pulled to take care of adults. That was a nervousness for us, or how do we ration ventilators? That was a big thing. Do we share the pediatric ventilators with adults? And I think that we were just worried how we continue to take care of pediatric patients. But once the COVID pandemic started really affecting pediatrics at first, fall of 2021, we had to pull out all the stops. We created a surge plan essentially overnight and had to do what the adult side had already been doing. And it hit us hard. Pediatric patients died. And I think that was a piece that the children's hospitals nationally were sharing with each other was, oh, wow, like this is affecting all age ranges. And we felt helpless. Like you put them on the ventilator, you put them on ECMO, you do the best you can, and you wait. And that is a really helpless feeling when the parents are just looking at you saying, please help my child. I think we saw a lot of pregnant patients on ECMO in the adult world. And so we went over to the adult ICUs to talk to families or partners about their baby and that their mom, the mom was dying and the baby right along with them if they were too early. I think that it was just kind of chaos and holding so much suffering.
Oh my gosh. How did the pandemic affect my job? How didn't the pandemic affect my job? I mean, the pandemic was my job. I mean, truthfully, there are a lot of areas of the hospital that the MICU definitely had COVID patients, but there are a lot of areas of the hospital that never really worked with them until it was later on. And so really it was us and then the ICUs that got them. It wasn't until later that they could start to go to other floors. So some nurses just didn't take care of them, especially on the onset. There wasn't anything that it did not impact. And I think that's what made it so difficult. There was so much uncertainty. We didn't know anything about it, and everything that we learned would just switch. We would, they would be like, okay, this is what you need to do. And then they'd be like, a minute later, no, we need to do this instead. And so you'd change like 20, 40, 30 times in a single day, just a practice of what you were doing. I think at the beginning, a lot of us felt expendable. And the reason I say that is, for example, the N95s that we wore. My entire nursing career up to that point, an N95 was one use only. You used it once, and then you threw it away. And you used it on, like, TB patients. Well, all of a sudden, this pandemic comes out, and the CDC is like, JK, you can use it for every single patient that you have. Well, they're not created to be used over and over and over and over again. And so we'd staple the straps back on because they would break. And you would use them until they were visibly soiled. You'd put them in a brown paper bag. What that brown paper bag did, I don't know. But they were like, just put it in a lunch bag. It'll be fine. Will it? I don't know. So it was, but it didn't stop us from going into those rooms anyway, So it just felt like not only were we worried about, am I really safe? But then you worried about, am I bringing this home to my family? So I knew people who lived in trailers outside of their homes because they didn't want to expose their family, or they lived downstairs and never went upstairs so their family wasn't exposed. I didn't see my family for a year and a half because of it. And so, that kind of created a perfect storm because then we isolated ourselves, which made it even worse. But yeah, it affected everything, every day.
Yeah, the pregnant women, it was horrifying. It was horrifying to know when a pregnant woman came in that the next steps, as you watch them decline, is, well, we're going to section your baby here at bedside, and your baby gets whisked away to the NICU, and they immediately get intubated, proned. And I can't imagine waking up when you come out of sedation, you're going to be confused at baseline, but then trying to recap like what happened, and you're not pregnant anymore and you missed that moment. We got a lot of postpartums too. So after, if they gave birth somewhere else and they were super sick, they got sent to us. And there was one from my hometown, and she almost died in CT scan. I was there the night with her primary nurse. I went down, and she had just gotten off ECMO, or I don't think she got ECMO, but she got sent to us from the CVICU because she didn't need ECMO, but she was still really, really sick. And I told the nurse, she was a newer nurse, and I was like, I'll go with you. We're just, she has high vent settings. We got to figure out what's going on with her lungs, like what's going on. And we get down there, and she is about to code on the CT scanner, and there's no one there. And Dr. Klima was on that night. And I luckily had her cell phone, because at the time, like, we had new phones and like trying to figure out how to call out. And I mean, she was seconds away from coding, and we went ahead and called the code. And so the ED came in, and we were like, we can't ventilate her, and she's blue. She's 20 years old. What is going on? And it was just, I mean, we figured out what was going on afterwards, but we ended up pushing her into the ED to get her into a bay so that we could get things that we needed to keep her alive and then get her back to the unit. It was very scary. And afterwards, I was like, I'm going to go take a walk and cry for a minute, because that was very terrifying to know, like, a child could be without their mother, and we're, it's just awful. And that nurse and I will talk about it, because I was like, it'll be fine, no big deal, we're going to scan, I'll go with you, just to like be a support person. And then I was like, and she looked at me, and I was like, I honestly don't know what to do right now, because we're bagging her, we're doing all these things, I don't know what's going on. We're not fixing her. It's scary. And Dr. Klima cried. That was like the first time I'd ever really seen her get very emotional. But it was just so intense. And so, like, we can't lose this girl because she just had a kid. And like, not that we couldn't lose other people, but like, can't lose this brand new mom who's in her 20s. So,
I mean, it was an adventure, I'll say that. And then in September-ish was when the vaccine started talking. Like, all of a sudden we had a vaccine, and it was working, and people were going to get it, and it was coming. And then we started talking about, okay, how are we going to vaccinate our employees and those pieces. And so then we spent sort of September and October planning for that. The vaccines came, people got vaccinated, and then in December it was, okay, now we need to figure out how are we going to vaccinate the masses, because it became very apparent Kentucky's a little bit different than some other spaces in the states, and we just are so rural. There's not another metropolis kind of space. I mean, there's Louisville and us. And even if you go to like Ohio or Indiana or even Tennessee, right? They have multiple hospital systems, multiple cities. We just don't. And so it became very evident very quickly that there wasn't really anybody going to own it. It had to be us. And how are we going to do it? And then all of the focus sort of switched from the hospital and the inpatient, which at that point we kind of had, to how do we build a vaccine distribution center? So, and then that's what we did. And then we just did both of those things for a really long time.
A CDC quality of work-life study showed that in 2022, nearly half of healthcare workers in the U.S. reported frequent feelings of burnout. While they faced extraordinary challenges in their professional lives, they also had to contend with personal challenges at home. Isolation, taking extreme precautions to avoid spreading or catching COVID-19, fearing for the safety of their loved ones, and attempting, as much as possible, to decompress and rest in their off hours.
I had so many things happening in my life leading up to the pandemic. In August of 2018, my dad passed away from a lung transplant that he rejected. And in April of 2019, my mom passed away. She was taking care of him, not really caring for herself. She ended up having a brain tumor, and she passed away a couple months after she was diagnosed. And then Christy and I got married in June of 2019. So then we got back from our honeymoon in August, and we're, living the early married life. And then, 6 months later, this is all happening. Christy went on vacation with her friends in March of 2020, the week that everything shut down. So she was in Kansas City with friends. All of Kansas City shut down, so they're staying in a place where they can only do DoorDash. Her friends were not sure if they were going to be able to get back to where they were living in California and Idaho. And then I was worried about Christy getting back, obviously. I provide that context of my parents. Obviously, losing parents but to have them then go through the pandemic when they were already both so sick was, it was relief that they didn't have to actually go through that, especially because my dad had a lung transplant and was, immune compromised. I was relieved that my parents weren't having to go through it. I was concerned about not having vaccines and what could potentially happen. Christy and I were very cautious, but then I just kept working. And I think a lot of people didn't keep working, and you ruminate in your thoughts and being alone and what's happening and not really knowing. And I kind of just dug into the data and to what was actually happening so that I could be informed when I was doing the interviews and I could communicate. And so I think that was actually probably a real positive thing, or a way to, I guess, cope by just working more than I ever anticipated I would be working during a shutdown where nobody else really was. So, and then, at that time I was doing all of the interviews, but then we were also trying to set up the assays in lab to analyze, large samples. So we were trying to get it set up where we could actually have a workflow and people working throughout the day to actually analyze samples. So, I was focused on all of these other things that was keeping me quite busy. So, and we were newly married, so yeah, we were doing all this locked together in a house. Yeah.
My wife and kids, at the time I had 2 boys that were both in sort of middle school, early high school. They've known that my job is as an ICU doctor, right? And so I have somewhat erratic hours. I have, when someone calls, I'm going to be there. I'm not always there at dinner. And at a baseline, that's been a struggle periodically with my family. I will say at first there was a lot of grace. There was a lot of understanding, right? They were scared. I think they felt much better when I sort of explained that my primary role was to educate folks about how to take care of patients that don't have COVID, right? And we're taking care of those patients, right? So there was a degree of relief, especially at first when it was not totally understood that, what kind of outcomes people would have. And before we were all vaccinated, I think there was a great deal of anxiety. But I think my family understood. I think if you would ask my wife, she was not particularly happy, right? But she understood that was the job, right? And someone needed to. And we had a whole process of, fortunately, we have a guest room that's downstairs in the basement. So we sort of had made an early rule of, if I wound up taking care of COVID patients, and ultimately I did, right, that I would go down there and sleep and rest. And we'd created a whole process in case that happened.
My family's very different. I've been in healthcare 26 years. My children grew up in healthcare. They're both going into healthcare. They knew. And so I stay away from home a lot anyway because I don't live here. I live 2 hours from here, as you know. And so I think the biggest change was my husband was like, you cannot work those 16-hour days. Come home, answer calls all night. You need to just get an apartment. That was probably the biggest change for us. But my husband works in an industry where he didn't get to stay home. He was having to get the COVID vaccines, learn how to do PPE. I mean, he works for Pepsi, so he was in and out of, the prisons and different places setting up machines. And so our life is so different at home, and they've just become so used to it. I think it really, other than just saying don't come home every other day, stay there, was really the only change for us.
Yeah, my husband and I are both physicians, and at the very beginning when we started taking care of COVID patients, we had this process where we entered the house in the basement, we took a shower before we greeted our kids. We saw our parents outside in the yard, and there was no touching and of strangers or giving hugs to the grandparents. It is a weird way to have a social interaction with people. And I think we worried we would be the cause of our kids getting sick. And, I wake up every day and came to work and saw kids sick with COVID and dying. And then I go back to my own healthy kids and just worry that I'm going to be the cause of that. It was a lot of weight to try to do the best we can to prevent it. I was really happy when we started getting some treatments, and I think the monoclonal antibody that we had for pediatric patients, we jumped on. I think we had our monoclonal clinic up and running in a week. It was like unprecedented speed because we were so desperate in the pediatric world for some kind of treatment.
To be very honest with you, I was scared at first, but I think once I sort of got, this is a respiratory virus. People weren't getting blisters on their skin and dying. It wasn't Ebola, right? I felt like we knew how to protect ourselves. I was just incredibly diligent about I went to work, I had a bag, my scrubs, they went in bags, they came home, I entered into different doors, my shoes stayed outside, everything got bleached down, my kids didn't ride in my car, it was a whole thing until we were sure about how long it could live. And it just took a lot of energy constantly thinking about did I wash my hands enough? Did I do this? Is my hair in the right place? Do I have the wrong earring in, right? All of those sorts of things you just don't think about. It just adds a lot of work to your daily life. And then you'd go to work, and just to get in and out of the room took 8 minutes of masks and, bags and things to cover yourself. And then you're in the room and, you're afraid to open the door and how's it going to come out? And there was also a lot of sort of management of other people's emotions that I think I didn't quite grasp at the time. My kids now talk about how, initially it was, oh my gosh, it's so wonderful that your mom is a doctor and helping with all this. But then it was, oh yeah, but we can't come to your house because my parents don't know if your mom might give it to you guys and give it to whatever, right? Even early, even before we were not mixing with people, it was, I don't know about that. I don't know about that. You got a lot of exposure. And then it was, everybody else was at home with their families. Everybody else talks about COVID in a very different way than my family does. They're oh yeah, that was when everything shut down. We were home. We were all, COVID puppies and COVID this. I worked more during COVID than I had in years beforehand. And I work a lot.
I also, I felt pretty isolated leaving work. And, in the beginning, I remember when that first patient came in and before it had really spread, I'd gone out to dinner with some friends and I was just no one here knows that there's a patient. And this is about, at the time I didn't think it was going to get that bad. So of course I was out hanging out with my friends. But then once it started spreading, it was the friends that even lived in Lexington. I was having Zoom calls with them just to kind of keep a connection. Because they didn't work with me and I wanted, I'm by myself and I am a single person. So I would go home to my animals and that was it. So that was really hard. And I know I chose not to go and visit my family because I didn't want to expose them. And when they were offering to be tested, that we had the drive-by testing, if I was going to go home, I would go and get tested before I would go see my mom because she's elderly, and I didn't want her getting sick. I didn't want her to be in that unit like that.
I didn't do much of anything outside of work except sit and try and decompress. I mean, honestly, and I'm very upfront about this because I think it's important to say, but it had a significant psychological impact. And I had mentioned before about, we all were like, oh, I don't want to take it to my family. And so we all socially isolated ourselves, which only worsened our mental state. I was anxious. I was depressed. I had PTSD. And the only reason I think I made it through all that is because I had thankfully had started going to therapy like in September of 2019, honestly. And so speaking of telehealth, that is one positive thing I can say about COVID, is that telehealth became like much more of an option. And so I had telehealth essentially for like 2 years with my therapist. And that is what truly, honestly, hands down, got me through. I think we will, for decades, still be learning things from COVID, because I think there's probably a lot of things we still don't know that what it has affected long term. There's recent articles about long COVID, like the effect of COVID long term on the human body, and we simply don't know what effect it will have long term in that regard. So there's that. But in terms of specifically for me, I make a point of talking about the need for self-care, the need to really prioritize yourself as a healthcare professional. There's that old adage, you can't pour from an empty cup, and it's true. Like, our patients deserve the best that we have, and if we are not our best selves, that's not what they get. Burnout and moral distress and, compassion fatigue, all those things are real. And if we don't take steps to improve our own well-being, then not only do we suffer, but our patients suffer too.
The COVID-19 pandemic has already made a significant mark on history. An essay published in the New England Journal of Medicine described COVID-19 as a once-in-a-century pandemic, the likes of which hadn't been seen since the infamous influenza pandemic of 1918. Throughout the uncertain years of the pandemic, healthcare workers were forced to adapt, improvise, and break down barriers in their efforts to not only care for the surge of COVID-19 patients, but to also ensure other patients got the health care they needed. These struggles led to many lessons learned. In a 1948 speech, British statesman Winston Churchill offered this famously and frequently paraphrased statement: "Those who fail to learn from history are condemned to repeat it." With this in mind, our guests think back to the most important things we should take away from living through the pandemic.
I would say I think that we learned that as a community, a healthcare community, we could pull together, right? One of the things I was tasked to do relatively early was we weren't sure after the New York, overwhelming infection that wasn't also going to happen in our hospitals, right? So we had to train a bunch of folks who were not normally ICU doctors to sort of be ICU doctors in case that happened, right? And there was no limit to the number of people that just stepped forward and said, "I'll do it." I think that was really encouraging to see, right? And as an organization, we stepped forward, and that was really, really positive, because sometimes it feels day to day that it's just hard, but having people that just stepped forward was great. I think the downside, I think we also learned, was that that we don't always treat each other well, right? We don't always treat each other with kindness, and particularly in a sustained level of anxiety, right? that sustained anxiety ultimately leads to friction between people, and I don't know that we even today know how to handle that well, right? How to navigate that interactions when I don't agree with you, right? Or I feel anxious and I want to react in some way, and you're the only person I can really react to because there's no one else around me that is able to do that. And I think that's a challenge that I don't know that we've uncovered yet. And I think that COVID was really an opportunity for us to see that, not at first, but over over the waves. I think we got to realize that was more and more a problem that as a society we need to think more about how we solve.
I think my takeaway, and totally echo what Dr. Hatton just said, but to add to it, we have always had a strong infection control team here. They're not always the people don't want to see them come, right? They're telling you wash your hands and do the appropriate things. But the amount of just effort that small team made for not only this hospital, but they were on calls with other hospitals. They were on helping the campus. That team and just reiterated to me how important they are to our healthcare. I think the other major takeaway for me is we as a healthcare system band together, but we could not have done it had we not been. We were blessed to have the campus. When I needed a new mask, someone down at the college made us some masks. When I needed hand sanitizer, they were making hand sanitizer. How many of my colleagues in the world can say that? It was an amazing collaboration. And I think it just really built, for me, relationships as I've grown and done other things here since then, that those people down there are just amazing to help us. And so I took that away as a positive, is those relationships. And working with our international team, and in different things. Had we not had that relationship, now that I'm bringing in international nurses, it's a partnership I would not have probably been able to say, oh, it's called a campus. So that was wonderful. And then I just think the physicians and the nurses working together. And to Dr. Hatton's, even when we weren't kind, we knew the end result was what we come here for every day, and it's the patients. Even though we're scared to death, we're going to take it on to our families, we're here for the patients and their families. And they were thinking outside of the box of how to help these people who, might all their family be in different rooms with COVID and several of them dying, and how do we make sure they're together for that last moment? It was miraculous moments that you're witnessing in healthcare during one of the worst times that I've ever lived through, honestly.
One of the most important things that did come out of COVID is that not only did it force me and our providers and everybody associated with healthcare to look at what else could telehealth do, but it really reminded the regulatory bodies, whether it was Congress, whether it was HRSA, anybody anywhere in the country that originally had been worried, well, we need to protect patients. We need to limit what we do with telehealth because this is a new idea. We want to be careful. Suddenly people began to realize telehealth proved itself during COVID. It took care of people that we might not have been able to take care of otherwise. And so certainly, as horrible as COVID was, I would never have wished that we go through that. From my perspective, my industry, use of telehealth, benefited from this change of attitude that we actually can do telehealth, take care of people. Yeah, it changed. We kind of always did the same thing, but the audience was so much more receptive to telehealth than they had been before. The idea of doing telehealth from a hallway into an emergency room, exam room, we never would have imagined doing that. Well, suddenly doing that, it got people thinking, well, if I can do this, what else can I do?
I would be amiss if I didn't talk about telehealth. This was a revolution for healthcare. We were dabbling in some areas. I know the OB teams had been at the forefront of telehealth, but it was not widespread. It was kind of a novelty. And really, in a week or two, we needed to turn it on. And that has been so helpful in so many different ways that we can reach patients in rural Kentucky in a way that we never have before. So I think for clinical access to care, this has been revolutionary. And I think kids get it. They can look into they already use their parents' iPhones or their parents' phones. They understand getting on a video and talking to their doctor. This is not, they did NTI throughout all of COVID. And I think that they understand this, they're technology natives. So that has been really a great way to connect with families. So I think that foremost has just really changed the face of medicine. I think for pediatric care, really taking care of the whole domain of mental health has been a major initiative for us. In every clinic, in every site, we really need to be thoughtful about what is weighing on pediatric patients. Even if you come in with a broken arm, we are doing suicide screens, or we're doing depression screens or high-risk screening, because we found that it doesn't matter what they're coming to be seen for, that there's still this underlying stressors that exist, and now we're really more attuned to that. So that's been helpful, and we're just building our mental health teams as fast as we possibly can.
There's so much to learn, and you learn from the pandemic, and there's so much to learn from history, and what we went through in 2020 and 2021 kind of mirrored a lot of what people went through in 1918 during the 1918 pandemic, and the social dynamics and and we saw it every day when Andy Beshear would give his daily presser. He would talk about, here's what it looked like was happening in 1918, and here's what's happening right now. And he was drawing very clear analogies. And I think, in general, our politicians and social health workers and, the community workers and our public health and, in general, do have the public's best interests in mind. And I think realizing that and making sure we don't get too far away from that recognition of the fact that most public health workers are actually keeping our best interest in mind based on the data that they have at the time, which does evolve throughout a pandemic that we've never had to experience before. And the same thing is true for vaccines, right? So when the mRNA vaccines are really what, I think kind of people think they came out of nowhere, but there was 20 years of research, more than 20 years of research demonstrating that, and it's that those basic fundamental studies that were done, 20 and 30 years ago, showing that mRNA, when you put mRNA into a cell, you can get proteins to be expressed. And then those studies were, many studies and a lot of funding led to them designing a vaccine where you can express proteins and you can induce an immune response. And then that led to, clinical studies where you're actually using mRNA vaccines. So did the mRNA vaccines come out of nowhere? I mean, COVID kind of came out of nowhere. We weren't anticipating it. And our ability to take that 20 years of research really led us to very quickly pivot to focus on COVID. But those mRNA vaccines were being tested for many other things, HIV and cancer vaccines. And, they were already in development. It's just SARS-CoV-2 came out of nowhere. So, came on very suddenly. So it was really that SARS-CoV-2 came on quickly, and the vaccines, the technology was there. The approval process, I think, was an incredible testament to to the politicians and to the scientists that were driving that. And I mean, that If they didn't initiate warp speed, we wouldn't have vaccines. And so it really was 20 years of research and then a political directive that drove the funding to actually support the technology to get it into people. So it's, so many moving parts have to come together in exactly the right way in order for something like that to have such a profound effect.
Oh my goodness gracious. I don't even know where to start with that question. So I think one of the things that I learned a lot was the truth is, to some degree, what people experience. And just because somebody says it doesn't make it real for everybody. I mean, I think to some degree it happened with us when we were watching this happen, this virus in China, and we were kind of like, yeah, whatever, right? Even though people were saying this could be bad if it got here, and we were like, yeah, whatever. But I think a lot of what I learned was no matter, we understood the virus, and I consider myself a scientist, but even when I was standing in the nursing unit talking to the nurse, and they were telling me things, and I was saying, that's not true. That's not how that works. They experienced it differently. And so helping folks understand what they need to know and how to communicate with them in a way that they felt like was real and that they could trust you was different for different groups of people. Right? What I needed to tell the nursing staff versus my mother-in-law versus, the doctors that were caring for somebody versus somebody's family member was different. And how I needed to present the information was different. I also think I learned a lot about motivation and that different people are motivated by different things. And for some people it was, I want to do the right thing. I want to take care of people. And for some people it was, I don't really care about that. I'm on this for me. So tell me how this is good for me, right? And they were never going to be motivated by, don't you want to do the right thing? Or don't you understand that this is bad for everybody else? They didn't really care about that, right? But it was still my job to motivate them. I had to figure out how to communicate with all those people. So, I think for me the biggest takeaway was, you can't ever over-communicate, and the way that you communicate with each individual group has to be based on their reality, not based on what I think it should be or what I know it to be, because it's not true, and it doesn't matter.
So I give a lot of people helped us with this. All of the vaccine clinic and the monoclonal clinic, we really turned around so rapidly with a view of how to help kids through it all. I think that's the part that I feel really proud of, is we didn't just sit kids in a chair and give them a vaccine and push them on their way. They were already traumatized by the pandemic. So we took a very kind of trauma-informed care approach where we said, here's who I'm at. This is what's going to happen to your body. These are ways we can control your pain. This is a sticker or a treat at the end. This is what we're going to do to you. And so you're part of the process all along. And all the team was really on board with all of this concept beforehand. And I think it got a lot of people's attention that maybe we should start taking care of kids in the same way. So that's some of the lasting legacy that I think we've been able to spread, is so now all of the locations that take care of kids have these options available to them to help kids with vaccine pain or this apprehension, or taking care of kids that have neurodiverse needs. We have sensory items, and it's really been a thoughtful way that we can shift the way we're taking care of kids. And I think this is all born out of the pandemic.
It was in the middle of COVID that I decided to return to school. I'm currently in grad school at UK doing my psych mental health nurse practitioner. And the reason I did that is for the reasons I mentioned previously. There are lots of hospitals get into this idea of you need to do this for the patients and this for the patients and this for the patients, and we do. We definitely do. But that's really impossible to do if all you do is just pile on, and don't allow any kind of reprieve from that. COVID made me acutely aware of how mentally fragile those of us in the healthcare are. And that goes across all disciplines. I mean, it's doctors, it's nurses, it's techs, it's RT. In my career, I've known 3 different people who've committed suicide. And that's abnormal, right? Like, there's a lot of and we don't talk about it. And I think that's one reason that I chose to do. That's why I became passionate about doing psych mental health, because there's tons and tons of research that shows that we have higher propensity for suicide. We have higher propensity for major depressive disorder and anxiety and PTSD and all the things, and we don't discuss it. We don't. We just kind of push it away, and we're really good about building up like walls, but we're also really good about taking care of everybody else and not taking care of ourselves. We're real. That's like our best thing. So I talk to new nurse students who come in for the ED, to new nurse grads. I talk to them about stress management, about how important it is to make sure that you're taking care of yourself, because this job is hard. This job is hard.
I would say we've learned that I'm not saying that before you didn't think of human life as valuable and as, I'm not sure what the word would be, but it felt to see, for example, at the beginning we weren't allowing visitors in, and a lot of these patients were dying, and their family members were watching them die over a TV screen, because we would do the EICU in a Zoom call and they would say their goodbyes. So for me, it's that making sure that whoever can be there in those last moments can be there, and really valuing that moment in someone's life that's unfortunately the last moments and exiting the world. It was more profound to me, and that part has really stuck out with me. It's the medicine ICU, unfortunately, even before the pandemic, saw a lot of death, and we saw a lot of death during the pandemic, and it was devastating, and it was hard. And sometimes we were the last people to talk to some of these patients ever, and to hold their hands as they were dying. I know that the mental health aspect is, for me, when I look back on it, I think I said this earlier, I have it in a nice little box that's tucked away. I wouldn't say it's a nice box, but it's in a box tucked away. But during that time period, I saw my coworkers struggle. We struggled a lot, and without each other, we would not have made it through, because no one understood what was going on in those rooms except the person that was beside you, working with you, including our physicians and our respiratory therapists, all of us. It felt like we were on this island that no one could understand. There was one time where we had a patient that was passing, and they were prone, so they were on their belly. And this was when we were allowing families in, and the family they couldn't be there. They had to leave because they couldn't watch their loved one pass away like this. And, when it started happening, my coworker was in there, and I called the family again, and I was like, "Are you sure you don't want to be here?" And they were like, "No, we've said our goodbyes." And I could see that the nurse, she was in all of her N95 and her gown, and I knew she was struggling with this moment. And so 3 of us went in with her and stood there and held that patient's hand. And we each had a hand on this patient while he passed away. And as horrible as that was, that to me is one of the best examples of what we did for each other to get us through. Because we could see just by looking at each other what you were thinking and how you were feeling. And we knew when we needed to step up and help each other.
It was a difficult time that I think still has affected our staff, and I think particularly the children that survived it all in our society will never be the same. I think the impact that COVID had on children's development and social well-being, it has erupted such a tsunami of mental health disorders in children that we don't have the facilities or the people to take care of all the needs. I think we didn't know to anticipate that this was going to be such a significant impact. They lost their social sphere, their school, their teachers, their coaches, their churches, all the things that help kids feel connected and loved and stable got disrupted, and they're still not okay. And I think that's the part that we're still grappling with, is how do we catch them up or help them be okay? And we're still struggling with it. We're building new teams and new providers and new ways of caring for them, but we have never encountered the amount of needs in our pediatric population for mental health support ever in the history of our field. So it's an unprecedented time that this generation of young children have been affected in ways that we probably won't see for maybe even decades, kind of wash out of our children's developmental phases. It's going to carry with them as adults and maybe even how they parent. So as pediatricians, we're always thinking about, we're raising the next generation of adults. And this is an important generational effect that we're really grappling with, how to help protect them and bring them back in a way that they can function in life. So it's been really a significant time in our pediatric field.
Decades from now, COVID-19 will be the type of historical event that will inspire questions from younger generations who weren't yet alive to experience it. What will be the lasting legacy of this pandemic? And what would our guests tell future children or grandchildren about their experience?
I would tell them it was a time period that I never want to relive. I never want to see that kind of sickness or the amount of death that I ever saw. It was scary. I think in the beginning, we were scared, and we were working together to figure out, how to take care of these patients. And we moved out of that kind of scared phase into, we're a team. And it felt like we were very supported by the community. And then, as time went on, it felt like the support kind of fell away. And that was really hard too, because we would still go in to our environment and feel how scary and how desperate some of these people were to live. They were suffering, and to see it go through that phase of, like, we were scared, we were a team, we had support, and then to lose the support a little bit is I didn't never want to go through that again, because it was like you were screaming. You were like, these people are dying, and And people weren't believing it. They were just like, this isn't real. The vaccines don't work. Don't get the vaccines. And I think losing that support was really hard. And to feel that, I know I was scared, but you had to put those emotions away to be able to do the job that you needed to do. And I was very proud of our unit to overcome that. And we couldn't have done that without the teamwork that we had.
So it's an interesting question about what I would tell my kids. And admittedly, I don't know that I've thought about it. But I can tell you that it's helped me to understand some of my interactions with my dad. He does not talk about his time in the Vietnam War. It's not a thing to talk about. He was drafted, and he went and he served and did what was required of him. And in a lot of ways, I sort of feel the same. It's clearly not, right? So I don't mean that, right? But it was my responsibility. I stepped forward. I did it. My kids don't know. They don't know.
I think that's the point, right? It's still so raw. Yes, it's over. We're looking at 5 years in, but it's really never over for the people that were doing it day in, day out. So it is that post-traumatic. It's not going to go away, and we live it every day still, right? I mean, COVID is still here. We still have flu. We have all the things, but that emotion is still there. And I think as you talk to others that lived through it and was on the front lines, you will still see that. It is so raw emotion for people. I think I might say, if I ever have grandchildren 3 years from now, don't ever think it can't happen to you and your loved ones, because it can. I think I've said to you in the years past, bugs are smarter than people at this point, right? I mean, every time we think we've got a bug under control with the right drug, it mutates and does something different. So we have to be thoughtful of the fact that those basics of infection control that your mother taught you to wash your hands and things are the number one thing you always have in your toolbox. And I think that's what I would tell the generations to come.
It was hell on earth, is what it was. I don't really think there's a better way to describe it. It was just so much death and sadness, and there are tons of adjectives and nouns I can use to describe what it was like to be with COVID, but be working in COVID, but none of them are positive. None of them. I'm proud of us for making it through that, but I don't know if another pandemic hit, man, I might need to find a new career. That was something. It was just, I don't know. I don't know if I could do all of that all over again. I do keep coming back. Just a glutton for punishment. It is fulfilling. It is fulfilling to be able to see a patient at their worst moment and have a positive impact on them. And we've gotten back to that, right? Like we have patients and they're sick and we do a bunch of stuff and they get better. And that's great. That's what was hard about COVID is they came in, they were sick, we do everything, and they die anyway. And that was so disheartening. So to be able to truly have a positive impact on a patient's mental state, on a patient's physical well-being, and taking care of their family as well. Like a lot of people being able to, a lot of times what I do, and one of my best friends makes fun of me, when people come and ask where I am at the desk, he's like, I don't know, she's probably giving somebody a hug. Because I do a lot of that too. I will, if I see like a family member struggling because someone's sick, because they don't know what's happening, I'll be like, would you like, do you want a hug? And that to me is just as important as titrating the pressors. But maybe not as important, but definitely important. And you get to do that. I mean, you do get to have positive impact on people's lives in their very worst moments, to be the calm in the storm, and to be able to be the one that's going to be like, it's going to be okay. We're going to get through this. And the people. I mean, honestly, it's like a second family. A lot of us stay because of our coworkers, and I don't know any other environment that's like that. It is baptism by fire, and when you have, when something is forged in fire, it's that much stronger. And I think that's why I keep on coming back.
I think for me, the thing about COVID that was most impressive or most memorable was just the feeling that the entire healthcare community came together in a way that I rarely see to solve a problem, right? Both with the original sort of design of the systems of care that we were going to provide, and with the building of the field hospital, and with the building of the vaccine distribution center, right? It was just this, hey, this is what we do, this is who we are. Nobody had any ego or attitude. There was never we can't do that, or who's going to do this. It was, what do you need me to do, and how can I help? And I think it sort of renewed my faith in humanity for those periods of time, and that if there's a real problem, we can come together and fix it, right? I think the vaccine center was, again, and it was this, okay, we have to do this. And we went to the first meeting and said, these are the things we need. And then you showed up the next day and they were there. Okay, so what are we going to do? We need this, and who's handling this? And again, it was just this wonderful outpouring of everything good in a human being, right? And in every human being. There just weren't any negatives in the group, because everybody was like, please let this work so we can have our lives back. We really want to take care of normal, really sick people again and do surgeries and things. And so, and just to watch it come together, and to watch the outpouring, even from the like the environment around us, not even the healthcare environment, just like the community, people showing up to volunteer, and hey, I'm not clinical, but I can type people's names in a computer and search them in a database, or I can shovel the parking lot, or I can provide lunch for the volunteers who are going to be there all day long, or but when we needed people to just, put all that aside and do a job, they did. And they did it without complaining and without any sort of sense of irritation or obligation. It was just, I'm here and whatever. I mean, I remember looking outside one day at the vaccine center. We'd had some snow, and it was in early days. And it was the first part of the vaccine distribution went to people who were really old and mostly sick, right? So we had all these 85 to 90-year-olds literally showing up to get their vaccines, and it had snowed and they couldn't get out of their car. And I remember calling and looking out, and there's a whole bunch of doctors out there with shovels, and they're scraping the thing and wheeling people in wheelchairs, right? This is not something doctors usually do willingly in the hospital, right? But, they were doing it here, right? No questions asked. And I remember looking over and seeing the dean of the dental school and the nursing school and the med school, pulling up vaccine and mixing drug and giving vaccine, putting in syringe. It was just, everybody was just I can do it. Show me how and I will. It was just absolutely an amazing organized system that I probably won't ever get to experience again, because it's what happens in crisis, right? All the rules sort of go away and you just get to do things without all of that. And then I think also the university's commitment, I think that was when I really I've always been we got to take care of, this is my job. And you hear that from people, but I think that was when I really sort of realized as a leader, wow, the university really means it. They really are, they gave money and resources and people. And then even after the first part was over and sort of the publicity, they were okay, how do we reach the people who didn't come? which groups did we not get to, and what are we going to? So when we built mobile vaccine centers, and we went to churches, and we went to regional areas where people spoke different languages and might have been sort of marginalized, and because it was the university said, we got to vaccinate everybody. We're never going to get through this unless we get this virus number down, and we have to do that by mass numbers, right? And we got to make everybody feel safe, and we have to talk to people in whatever language is real for them, right? Their reality. And it was interesting, because I think that was when I really began to recognize that the university, the people who make up the university, really do back what they say, right? That when it came to time to put your money where your mouth is, they did. And even the people who I don't necessarily think the same as on a daily basis, and we might have different ideological outcome or outlooks on life, it didn't matter at that point, right? We were there to solve a problem, and it just worked. So I think to me that was the part that was just amazing.
Yeah, I wonder if it's going to have the same kind of mystique as the Great Depression did. I hear my parents and my grandparents talking about living through the Great Depression and how much of a mark that made on that generation. I think that we're going to see something like that we're going to see that COVID made this same kind of impression on our generation. I think there'll be some good things. I hope there's post-traumatic growth of all the things we've been through. I see our teams getting stronger even through all of these things. They've worked together every day, and I think that has been really beautiful to see. I hope that children have learned things about how still to have social connections, and I think that's part of emerging out of trying to stay away from people. And that's a hard thing when you've been isolated in a really developmentally vulnerable time in your life. These school-age years are really important in a child's development about themselves and how they relate to others. So I do hope that we create supports to help them grow into healthy teenagers, and the teenagers grow into healthy adults. I think it'll be a really significant mark or scar that maybe we live through, and we show our grandkids, look at this scar, and let me tell you the war stories that we've been through. As a physician, it is a time of bravery. I saw so many brave physicians come to work every day knowing they may risk their lives. I think when I think of what it boils down to be a doctor and why I got into this work, it's to do that, right? To help others in a way that you pour out yourself to help other people. And I saw people do that every day here. And that's really helps clarify what's most important in life, what we do, how we help others, how we love each other.
As current UK President Eli Capilouto often says, we are not just the University of Kentucky, we are the University for Kentucky. The people of our healthcare system worked tirelessly to care for thousands of Kentuckians with COVID-19 throughout the pandemic, often while enduring great professional and personal hardship. The past 5 years have been difficult, but they've also provided seeds for the university and UK healthcare to grow. From new research projects, to the expansion of telehealth, to the development of a new pandemic-ready ICU, and more. The UK Medical Campus has risen to the challenge to find newer, better ways to advance the health of Kentucky. Thank you to our guests today for sharing their personal, often difficult memories from the COVID-19 pandemic. And thank you for listening to this episode of Behind the Blue. Behind the Blue is a joint production of the University of Kentucky and UK Healthcare. For more stories about UK and UK healthcare, visit uknow.uky.edu.